So we move on, and now we have a speaker from Armenia. It's Alisa, and Alisa, please apologize if the last name, if I do pronounce it in the wrong way. It's Movsysian. So we are happy to have you here with us, and you will present a case report of acute myeloid leukemia following the exposure to cytotoxic therapy for breast cancer. We're looking forward to your talk.
Thank you. Good afternoon, everyone. I'll present a case of therapy-related AML. So the patient is a 53-year-old woman who admitted to the hematology center with 3-week history of fatigue, fever, and bone pain. We performed CBC, which showed anemia, thrombocytopenia, and leukocytosis. The peripheral blood smear showed 91% blasts. We also performed bone marrow aspirate, which was cellular, containing 84% of myeloid blasts, and the depletion of normal hematopoietic precursor cells. Immunophenotyping revealed 2 clones, myeloid and monoblastic, and the cytogenetic analysis of bone marrow by FISH revealed inversion 16. The patient didn't have organomegaly and lymphadenopathy, and okay, so we diagnosed myelomonoblastic leukemia. Before admission 2 years ago, the patient was diagnosed with breast cancer, and was treated with surgery, chemotherapy, and radiation therapy. Unfortunately, we don't have medical records of previous treatment, but in general, it was chemotherapy, surgery, and then radiotherapy. Family history was complicated with lymphosarcoma in both parents. Sorry. So we started the treatment with induction therapy with 7+3 regimen. The patient achieved complete remission and then received consolidation therapy with 7+3 and 3 cycles of high-dose cytarabine. And currently, the patient is under follow-up. And here, I just wanted to point out that the patients are at risk of developing therapy-related myeloid neoplasms after exposure to cytotoxic therapy. And the prognostic and preventive measures are very important. And taking the advantage of being at this stage today, I wanted to present this to tell you about the registry of blastic plasmacytoid dendritic cell neoplasm that is currently being collecting by our colleague at the head of adult hematology clinic in our center. And this is a rare disease, and it's very important to collaborate internationally to collect data about clinical aspects, diagnostic and therapeutic approaches of this disease. So for further information, please contact our colleague. Thank you. I'll be pleased to take questions if you have so.
Thank you very much, Alisa, for presenting this case. Are there any questions from the audience? So maybe one question from my side, or I start. This was the inversion 16 was the only aberration, or did you also look for KIT mutation or TKD mutation or other co-mutations in this case?
We checked a few mutations with our limited resources, and this was the only mutation we found.
Yeah.
Yeah.
And do you also perform, I mean, this is an excellent marker to perform measurable residual disease monitoring. Is this something that is performed in your institution to monitor the patient and to...
Okay, in this case, no, but usually we do. But since it depends on it depends from patient to patient, because it's not free for patients, and if they agree, we do it, of course. Yeah. In this case, we didn't perform MRD.
And I'm curious to know, I mean, when we do the family history on, when we talk to the patients, I often have the feeling that this is, that the awareness to really talk to the patients and ask in detail about the family history, that it is not 100% in all institutions. I think this is a very important issue. So how is this performed in your institution when you see a patient with a newly diagnosed AML, and are you on a regular basis really going into the family history and ask for the first, second, third generation?
We ask sometimes patients they hide information, but usually they answer, but we always ask about about parents and even more generations. Yes, of course. Yes, it's like usual routine. Yeah.
Maria Teresa.
So thank you very much. And thank you for this case and also for joining us to the meeting. Yeah, I just wanted to comment on the inversion 16. This was only 2 years from the diagnosis of breast cancer. So this looks like really one of these recurrent translocation setting after topo 2 inhibitors therapy, which is usually part of the treatment of breast cancer. So I think this was an exemplary case. Thank you.
Thank you. It was a pleasure to be here today. Thank you. Thank you very nice.
Thank you, Alisa.